Center for Social Research. And on behalf of the center and Dean Nancy Smith, if you would mind standing so that Dean is here in the School of Social Work at UB. On behalf of the school, the faculty, and the staff, and myself and our research associates, we welcome you to our fall Distinguished Scholars Series event. And our speaker, Dr. Thomas Sloan, who's come all the way from Hawaii in order to provide us with the social series. And I'm excited to join us. I've got kind of a formal bio sketch I'm going to read you, and I just want to share a couple thoughts with you about him. Dr. Vogt is a physician and epidemiologist with extensive experience in health behavior change, especially diet, weight management, and smoking. Health services research in quality improvement, collaborative clinical trials, and cardiovascular and osteoporosis epidemiology. He has a particular interest in ways to improve the effectiveness and reduce the cost of preventive care and chronic disease management. Dr. Vogt received his MD from the University of California, San Francisco in 1971, and his MPH from the University of California, Berkeley in 1974. He has served on the faculty of UCLA, the Oregon Health and Sciences University, and the University of Hawaii, where he held the M.J. Sullivan Chair of Cancer Research Center at Hawaii. He joined the Kaiser Permanente Center for Health Research in 1978, where he served as principal investigator for clinical sites of several multi-site NIH-supported behavior trials, and as PI of the Coordinating Center for the Dietary Approaches to Stop Hypertension, the DASH trial. In 1999, he became the founding director of the Kaiser Permanente Center for Health Research Hawaii and a member of the National Research Council of Kaiser Permanente, which he chaired from 2004 to 2006. Dr. Vogt's current research interests focus on improving preventive care, particularly long-term weight management, health quality care, and reducing health care costs. He is the author of 120 peer-reviewed publications and 3 books. His most recent book, Implementing an Electronic Medical Record System, Successes, Failures, and Lessons, addresses the challenges and potential of introducing electronic medical records in the healthcare system. That's for the bio-sketch policy. So I wanted to share with you a little bit about what I know about health. I'm very pleased but not surprised when I invited him to be accepted the invitation. When I was an assistant professor in Tennessee, I got a book contract to edit a book on preventive interventions with adults. And as an assistant professor, and I was in social work, and I was in Tennessee, and I needed someone to write a chapter on hypertension prevention with adults. And I went on Google and I thought, well, here's Tom Vogt. I think I'll send him a letter. So I just write him a letter. And I don't know what Tom has ever talked about. I don't know what he thought when he got it. He got this letter from his assistant professor of social work in Tennessee asking him if he would like to write a chapter for free for the book community. But I would give him a free copy of the book if you much to my amazement over time. As soon as I've gotten to know him over time, I've come to recognize at one point, I think in an email to Tom, I said, I'm beginning to learn you're someone of importance in your world. Because I really didn't have a clue who I was interacting with and how fortunate I was and how generous he was, and he agreed to write that chapter for me. Along the way, he's also mentored me in a variety of ways and been very generous in how he has connected me with colleagues from other universities and research centers to write chapters for me and to do various consultation things and grants. He's currently serving as a consultant on one of the NIH grants in Southern California. So I'm very grateful about how generous he is. And so when I asked him to come as our speaker, one thing I've heard about him is there aren't too many things he dislikes more than getting on a plane and flying to the East Coast. But in typical Tom fashion, he didn't hesitate. He was very gracious and accepting. So I'd like to introduce our distinguished scholar for the fall, Dr. Thomas Vogt, who is an exceptional physician, scientist, but a really generous and gracious colleague. Tom Vogt, thank you.
Well, good afternoon. It's really nice to be here. If you have any trouble hearing me, please let me know. Catherine was awfully nice to me in that introduction. I wish I had it recorded. I could show it to everybody at home. I am going to talk to you today about a subject that is really dear to my heart, because when you give somebody this much time to just say whatever they want to say, it's very different than having somebody call you up and say, "Oh, will you come and talk to us about techniques for getting people to lose weight or methodologies for doing randomized clinical trials." That's usually not what you really want to talk about. What I really want to talk about today is this subject here. And I have a real passion for learning how to do our healthcare better. As you will probably become aware as we go on, I think there are some real problems with our healthcare system, and we have a long way to go in order to fix them. I do believe that the U.S. healthcare system is in deep trouble, but I think that new information technologies offer us some real resources and help in getting out of that pickle, and that in order to get out of it, we have to change the way we do things. Now, it's campaign season, silly season again, and for the next year and a half, or at least until November of next year when we have a presidential election, you're going to hear a lot about healthcare from the various candidates. Most of it will be silly, uninformed, and what is not silly and what is not uninformed will be halfway measures, because frankly, to really fix the healthcare system requires actions that aren't politically or socially acceptable to us right now. But I'm hoping that the more people become informed, the more the actions we need to take to save our healthcare system will become acceptable. U.S. healthcare, for a lot of historical reasons I don't have time to go into today, nobody's fault, just historical reasons that led us to this point in history, have produced a system that's really strange. Regulatory, legal, and cultural incentives prevent us from setting priorities. We don't set priorities. That's not how we go about deciding what's going to get funded and what's not in healthcare. We can't manage costs to optimize outcomes. My gosh, if we did that, our healthcare system would look utterly different than it looks. We can't stop doing what doesn't work. We can do new things. We can pile new technologies on top of old ones. But God forbid you should decide that something we did last year wasn't really very good and we can't do it anymore, because we can do more good or get better results from this new approach. You've got to now deliver both of them. So we end up delivering vastly excessive care to the people who have insurance, and a consequence of that is that we have 48 million people, and rising rapidly, who don't have any health care at all. Now, you'll hear this again later as we go through this, but I want to let you know right at the top that when we talk about developed nations, we are the only developed nation that essentially lacks something very close to universal health insurance. Keep that in mind as we go on. Now, I know this is a long talk and it's hard to sit here, and I don't want you to look for deep meanings in the pictures that come up occasionally. I just wanted to throw a little culture in and get the people who are losing the thread of what I was saying to something to look at. So I was originally going to put some great masterworks of art in here, and then about the time I was writing this talk, I started getting these emails from our legal department saying, "Oh my gosh, you can't put anything in your talks anymore because everything's copyrighted. Don't take anything off the internet. Don't take anything off a poster or out of a magazine. Everything puts you at risk. So just don't do anything." So I decided I had to draw my own pictures. And except for the clip art in here, they're my pictures. So don't worry about copyrights. Okay. The U.S. healthcare system, however, like this little red bug, is somewhat lost in the forest, probably more lost than the bug. Let's begin by looking at what's going on in healthcare right now around the world. This is the annual per capita healthcare costs from 1960 through 2005 in the USA case in 4 nations. And of course, the blue bars tell you something right away. Our costs are growing at a much higher rate than other people's costs. The mean change in healthcare costs in the United States over those 45 years is 12% per year. And at this rate, mean per capita cost will be about $800,000 per person by 2050. You got that much for healthcare saved up? The mean change in U.S. gross domestic product for the last, from 1993 to 2002 for that decade was 3.22% per year. And if you will recall, except for the last couple of years there, those were really pretty good years in terms of our economy. So healthcare is growing at 4 times the rate of the GDP. Here is healthcare costs as a percent of GDP over that 1960 to 2003. And at this rate, by 2045, healthcare costs will exceed gross domestic product. We'll be spending more on healthcare than we're generating in our entire economy. Now, I first saw a graph like this about 20 years ago, and it said much the same thing. But appended to it was the note that, of course, this can't continue to increase this way. Well, it's 20 years later, and it's still happening, and there's no evidence of slowing down. And I'll add the same note. Of course it can't continue. Something's going to happen, and that something very well could be economic collapse of our entire healthcare system. Now, it isn't necessary that that happens, of course. We could do other things. We could learn from other nations where this isn't happening. But so far, we don't seem very inclined to do that. We are just looking at this as inevitable, and we get little patches proposed to us, or we add costs because we have so many people with no health care. We've got one side of the aisle saying, well, if you're not working, you don't deserve health care. And we've got the other side of the aisle saying, everybody deserves health care, so we'll give everybody the same health care that the people who are insured have now. Well, neither one of those solutions is tenable. We can't afford to do the latter, and it's immoral to do the former. This is a recent article just this year from The Economist in which the well-being of children overall and in health for 21 developed nations was ranked. Guess who ranked last? Overall health, overall rank, we were 20th out of 21 in children's well-being, and in health, we were last. Now, I really think most Americans are not tuned into this. We think we're better than everybody else. We've got the best healthcare system. We're the richest nation. Everybody's well off here. Well, we are the richest nation. But how we are using that wealth is not very equitable. And our children are paying the price for it. So let's ask some questions. If I ask you why you think healthcare costs are soaring, I think some of the answers I get are the ones I'm going to dispel right now. Hospitals are expensive. We probably put too many people in the hospital, right? Well, on all these graphs you're going to see the next few, the bright red line is U.S. And as you can see, there are lots of countries that put more people in the hospital, and the trend is downward in our country. We put fewer people in the hospital now than we did 25 years ago. Well, if it's not hospitals, then it's probably drugs. We all know how expensive drugs are, and we've all heard about how much we're paying for drugs in this country, which is true. We are paying more than any other country in the world for our drugs, but we're not giving more of them out. Compared to those other nations that we're looking at, we're near the bottom in terms of the proportion of pharmaceutical prescriptions dispensed. Well, how about just having all those hospital beds? Hospital beds cost a lot of money. Hospitals are very expensive institutions. Maybe we just are overbuilt. Well, again, that's not it. Well, doctors cost a lot of money. They earn a lot of money. So we probably have too many doctors, right? No, we don't have too many doctors. Most of those countries providing care for less than we do have fewer doctors. Have more doctors. Well, it's probably because we got so many old people. Everybody knows about the boomers, right? I'm on the leading edge of the boomer generation, and it's my fault that healthcare costs are soaring. We live so much longer than those other countries. Well, not actually. We don't. Among this group of 19 developed nations, we rank either last or next to last in life expectancy. It depends on which set of statistics you look at, whether Denmark ranks just above us or just below us. But we're pretty close to them. Look at Japan out there. Their average life expectancy is the greatest of any of the major nations in the world. There are some smaller nations that have longer life expectancy. And they spend less than half of what we do on health care. As a matter of fact, there is no nation on that chart or anywhere else in the world that spends more than half what we spend per capita on health care. That's an amazing statistic. Nobody spends more than half what we spend on health care in the whole world. These are the countries that spend less than half of what we do and have greater life expectancies than we have. If you want to look it up, you can. It's come from the CIA Factbook. This is an official government publication. It's not propaganda, well, unless you regard what comes from the CIA as propaganda. All of these countries have longer life expectancies than the U.S. And some of them are not countries like Puerto Rico and St. Helena. They're small, semi-autonomous regions for which there's separate data. You could just if you want to live longer, you could just move to Macau or Andorra. That looks like a good act to follow. So that raises the question, well, it isn't all these things you probably thought of. It's not hospitals, it's not doctors, it's not drugs. Why do we have such an expensive healthcare system? Well, I'm going to read to you some quotes to get into that discussion. This is a quote from Archie Cochrane, and it's personal communication. When I was a young assistant professor at UCLA, I was fortunate enough to have a lunch with Archie Cochrane, who is just a legend in epidemiology. He's now his name is the name that from which the Cochrane reports that you may be aware of is derived. Archie Cochrane was a notable curmudgeon who liked to punch balloons, and it's actually worth telling a short story. It's one of the advantages of having a long time to talk. I can tell you a story. And at the same lunch, Archie Cochrane told me the story about what happened in Britain in the early 1970s when there was a push to introduce coronary care units into the National Health Service. Coronary care units, starting in the late 60s, were the new way to take care of people who'd had heart attacks. You plopped them in this special unit with beeping monitors and 25 nurses in stations surrounded by beds, and they jumped on them immediately when they had a cardiac arrest and did CPR and gave them all the magical drugs and saved their lives. And everybody knew that coronary care units were, simply going to supplant usual care which had been in a hospital room for myocardial infarctions. Cochrane was concerned about this because he thought, my gosh, the last thing in the world a person who has myocardial infarction needs is a lot of stress and stimulation. And is there anybody in this room who has never been in a coronary care unit? Raise your hand. Anybody never seen one? Good. They're pretty, one hand I saw. They're a pretty stressful place. Can you imagine trying to relax, knowing you just had a heart attack, lying in this place with people running around, 2 beds down, they're doing CPR, pounding on somebody's chest. They're running up, checking your monitors every so often. They don't let you sleep, of course, because they have to check your blood pressure and everything else every few seconds. Well, okay, not quite that often. They're stressful places. And they do good things for people who have serious illness. Cochrane thought, but, for the person who comes in and they don't have heart failure and they don't have complications, wouldn't it be better to just send them home? Well, that was his proposal, and it was met with just total derision. But he was also very influential. So he managed to talk the cardiologist in the National Health Service into allowing him to do a randomized clinical trial in which patients with simple, uncomplicated myocardial infarctions and who had a caregiver at home, to let them go home or go to the CCU. But they said, we have to meet every week. And if there's any evidence at all that sending them home is killing them, we're going to stop this trial. So Cochrane agreed to that. Next Friday came up after they'd started the trial. It was the first week's report. He walked in the room and he wrote on the blackboard, CCU 1, home 3. And those were the number of deaths in the last week in the people who had been randomized. Pandemonium broke out. They demanded the trial had to be stopped. Cochrane said, but these numbers aren't statistically significant. They're just 1 in 3. Didn't matter. The cardiologist said 300% increase in deaths is not acceptable. We have to stop the trial. At which point, Cochrane said, well, I confess I got the numbers mixed up. It was really 3 who died in the CCU and 1 who died at home. At that point, they all agreed that it wasn't statistically significant. And the trial continued. At the end of the trial, the people sent home had statistically significantly lower mortality rates than the people sent to CCU. The trial was repeated and got the same results. And how did that affect care? Not at all. We still send them all to CCUs. So much for evidence-based medicine. Cochrane told me at that luncheon that he thought 90% of the care we give is unnecessary. And I said, 90% of the care we give? He said, oh, no, not you. We, in Britain, 90% of our care is unnecessary. And in the States, it's 95%. This is from Uwe Reinhardt, who I think is probably the leading health services researcher in the United States, and also an incredible speaker. If you ever want to have another good speaker here, invite him to come over from Boston. He said, our focus should be on eliminating the gross inefficiencies in the U.S. healthcare system. If we did that, we'll be able to cover the uninsured and spend less than we do now. Now, that sounds like a pretty outrageous statement, but you know what? It's true. Donald Kennedy, science editor, 2003. The U.S. healthcare system becomes a more embarrassing disaster each year. Henry Aaron, New England Journal of Medicine, 2003. I look at the U.S. healthcare system and see an administrative monstrosity, a truly bizarre melange. Roger Bush, 2007. JAMA, an epidemic of waste blights the U.S. healthcare delivery system. The system is not safe, is not effective, is not efficient, is not patient-centered, is not timely, and is not equitable. And this one. This is from the U.S. government, from the White House website, and it is not meant to be a criticism of President Bush, because I think the Republicans and the Democrats are of one mind on the issue. They simply don't, or haven't, maybe until this election year, recognized the true depths of our failures of our healthcare system. The White House said, and you've seen that all this stuff was known back in 2003, that President Bush was committed to assuring that the United States continued to have the finest healthcare system in the world. And that very ignorance of what is going on is, in fact, a major part of the problem. And as I said, this isn't a partisan criticism. Okay, the situation's pretty serious. But after the system collapses and we really sit down and dissect the results, we can probably figure out what happened. But I believe in preventive medicine. That's been my whole career, prevention, so I'd rather not have to conduct the autopsy. Why is it that we spend so much more than other nations? Well, this one I'm sure you've heard about. NIH is trying to make a big deal out of this 18-year gap or 17-year gap that the Institute of Medicine has talked long and loudly about. And it's true. Believe me, anybody, I work and have for a good portion of my career in a research institute situated within a large integrated healthcare system. And that means that we're doing research all the time inside a system trying to figure out how to do things better. And we do figure some of those things out. And then we say, look. And everybody says, oh, don't bother us, we're too busy. And they don't pay attention. One of my favorite stories is that one of my colleagues, a man named Jack Hollis, who's based in Portland, Oregon at the Center for Health Research there, did a randomized study a number of years ago that was looking at how can we get more people who smoke through the healthcare system to help them to quit smoking. And he did this really simple study in which he got the doctor to buy in to advising a smoker, unselected. Any smoker walks into the door into the doctor's office gets this message. You know, quitting smoking is more important than your other health problems. The first thing you should do is quit smoking. That's all. It took 20 seconds of the doctor's time. Then the nurse sits the patient down, shoves a video into the machine, and the patient watches this video for 7 minutes. And the nurse comes back and says, you ready to quit? And that's it. That's the total investment. The doctors loved it because actually they ended up spending less time advising patients to smoke, because when they had emphysema patients and cardiac patients, they were really spending a lot of time on it, and now they didn't have to spend any. The randomized trial showed that the long-term smoking cessation rate of people who got this was 4 times as much as if they didn't get it. It was in a lot of journals. It was written up. It became the basis for the national AHRQ recommendations on smoking guidelines in clinical practice. And Jack was hired by Stanford University to come down to Stanford Hospital and teach them how to do this. And they did. He went down there, trained them, and about 1.5 years later, they wrote a little report on how well it had worked for them, at which point Kaiser Permanente in Portland, who was Jack's employer, hired the guy from Stanford to come up and teach them how to do it. So there is no honor in your own country, but that's just a law of nature, I think. We don't set priorities that maximize benefit. If we did, we would do almost everything differently. For example, what screening service is the most likely to be delivered in this country, do you think? Is it? I mean, think about screening. Screening for your blood lipids, cholesterol screening, screening for breast cancer, screening for colorectal cancer, screening for prostate cancer, all the other screenings you can think of. Let's not forget cervical cancer. That's a pretty common one. Which one is the most likely to be delivered? The answer is breast cancer screening. Which one is the most effective in saving lives? Anybody know? Colorectal cancer screening. And guess what? That's the one that's least likely to be delivered. And, partly that's because it's more distasteful, frankly, to have colorectal cancer screening than it is to have all of those other screens. But if you look through what we do and what we don't do, it's not related to cost outcomes at all. It's not related to how many lives you can save for each dollar you spend. Not at all. We don't relate the costs of care to outcomes. And if we did, we could save a lot more lives because, let's face it, if you've got one service that'll save 100 years of life for $1 million and another service that saves 1 year of life for $1 million, why would you deliver the second one and not the first one? But that's what we do. We can't stop doing what doesn't work. I mentioned that earlier. When we have a new technology that comes in, we don't remove the old technology. We just keep doing both. And usually, we'll now order both. Oh, Well, let's get a CT scan and an MRI. And while we're at it, let's get an X-ray too. And we end up piling excess care on excess care. We do too much of what does work. And this is one of the biggest reasons. Imagine you're a hospital administrator in the United Kingdom. And you think this new technology, let's use MRI as an example, because when it came in the 80s, it imposed very big new expenses on the healthcare system. Should we or should we not put MRI units in our healthcare system? Well, the British, and in fact most developed nations, have a formal mechanism for answering that question. They have a panel that reviews the evidence for new technologies, and when the evidence seems to suggest that this technology is justified, it works, they then say yes, they put their blessing on it, we need to budget to put this into the system. The next step is they say, where can we distribute this technology to get its maximum, most efficient use throughout our population? And they then distribute the systems economically to serve the whole population with the minimum number of units. Now, in this country, here's what happens. You're the administrator of hospital number 1. And you find out one morning when you wake up that hospital number 2, your competitor 6 blocks away, has just bought a new MRI unit. Your response is, we better get ourselves one of those MRI units because otherwise the patients will all be sent down to hospital number 2. So you go out and you buy one. Now, both the folks in hospital number 2 and in hospital number 1 are going to say to their physicians, we got a new MRI unit, we got to pay for it, order, order, order. And that's what happens. When MRI units were first approved in Great Britain for use in their National Health Service system, they had decided originally that 17 units could serve the needs of their entire population, strategically placed. And at the time, in the city of Los Angeles, there were 57 such units. Now, the costs of that, multiplied by literally every technology that we have, are enormous. We do too much of what does work. These are not useless technologies, but they are overused. The New England Journal of Medicine published an article about 6 or 7 years ago in which they compared what would happen in the United States if we adopted only one thing from the Canadian system. The issue was we do everything we're doing now exactly as we're doing it now, but we have a single-payer system like Canada does. One check. $65 billion a year was the estimated savings. And for those of you who don't have a medical background, I'd like you to imagine what it's like for a physician trying to survive in a private practice in a small town. In the old days, the physician, if he was successful or she was successful, would have a nurse and a receptionist. And that was all that was necessary. Now, the patient comes in with one of 600 to 800 different health plan coverages. And the patient doesn't know what's covered. The physician doesn't know what's covered. And when you call the insurance company, the person you talk to there isn't even sure about what's covered. So you engage in this exchange that goes on for weeks and sometimes months to even figure out what's going to get paid for. And all of that costs a lot of money. So the physician has now had to add to his staff 3 or 4 people whose sole job is dealing with billing. This is an unnecessary cost that literally is not paid by any other country in the world. There are countries with multiple payer systems, but multiple payer systems in those other countries might mean anywhere from 2 to 6 or 8 payers, not 200 insurance companies, each of which has 7 or 8 or 10 plans. We don't systematically learn from our experiences. We keep repeating the same mistakes we made last year. And I'll talk enough about that in other contexts that I won't be more specific now. And everybody, this is one everybody's tuned into, malpractice. Oh yes, we do have an exorbitantly expensive malpractice system. But the truth is, even though the physicians think of this as a big problem because they're writing checks for their malpractice insurance, they're really aware of how much it's costing. It's really a fairly modest part of our excess costs, probably around 6 to 8% of the costs of the excess over other countries is related to malpractice. But that's still a lot of money. Now, we do have very strange drug and device patent laws. We like to talk about our free market system. One of the real ironies is that we really have less of a free market system than the French, who have what we would call socialized medicine. They have a single payer system. But when Merck comes out with a new drug and France wants to buy it, France goes to Merck and says, hey, we'll give you X dollars per 1,000 pills for that drug. And Merck said, oh, no, that's not enough. We'll sell it to you for 3 times that much. At which point France says, no, there are satisfactory alternative drugs. We'll go to GlaxoSmithKline. At which point Merck says, well, no, wait a minute. Don't go away. We can talk. And pretty soon they arrive at agreed upon price. And here's the amazing thing. France agrees to pay that price in perpetuity. As long as they are buying that drug, they will pay that price, even after the patent expires. I think, folks, that's a free market system, isn't it? And that's what cost negotiation is. You go to the lowest bidder. France, with its single-payer socialized medicine, is engaging in a free market bargain with the drug company in order to get the best price on drugs. In this country, we don't do that. So Merck sells that drug to our own providers for 3 times what they're selling it to France. You can buy that drug cheaper in any other country in the world than you can buy it in the place where it's manufactured. And furthermore, if they ship it across the river from Detroit to Windsor, Canada, and they turn around and ship it right back, it's no longer safe in the eyes of the government. Congress won't consider reform. And I think if they didn't know it before, every elected politician is acutely aware of what happened to the Democrats' control of Congress in the 1994 election as a consequence of the attempt by the Clinton administration to reform health care. Now, that health care reform was well thought out, even though, frankly, it was a halfway measure. It wouldn't have gone far enough. It was well thought out. But what happened to all of those people who supported it? They were gone in the next election. The Clinton administration lost control of Congress and never regained it. And the message has not been lost on Republicans or Democrats ever since. If you tackle health care and the big bucks in health care don't like it, you'd better pack your bags and go back to where you came from. And I will show you later on at the end of this message exactly how much money they're getting, the congressmen or people in Congress are getting from the healthcare industry, because you can't have that much money in an industry without somebody getting rich. And believe me, people are getting very, very rich in this industry. And they want to be sure they continue. So let's summarize before we change topics. We spend more per capita on health care by a factor of 2 than any other country. Our outcomes are overall among the poorest of all developed nations. We do have superb care. I'm not saying that you can't get good care in this country. We have the best care in the world if you're adequately insured and you have access to it and can get in there. We are the only developed nation that lacks nearly universal health care. And our health care costs are so enormous and escalating so rapidly that they literally threaten the soundness of our economy. We spend more, for example, in healthcare now than we do on the military, which is we spend more in healthcare than we do on the military, which is something new in our history. And this system is, frankly, an unsustainable disaster. It is not sustainable. And burying our heads in the sand and pretending that we can keep doing this the way we've been doing it is self-destructive. The greatest threat to the quality of our health care is, in fact, the notion that it should be unrestrained by cost. When I was a medical student, I vividly remember a lecture in which one of my classmates raised his hand and had the temerity to ask if the recommendation that the lecturer was making wasn't unnecessarily costly. And the lecturer just stopped short and glared at this young man and said, "It is immoral for a physician to consider the cost of the care he is going to deliver." And I guess after all these years, I would turn that around and say, it's immoral not to consider the cost. And this country is now paying the price, especially the people who can't afford care, because we're the only nation in the world that doesn't ration care, we ration people. Everybody else says, when it gets too expensive, we've got to give care to everybody. We can't deliver it. But we say, when it gets too expensive, we'll just take health care away from somebody and toss them out of the system. I have an article in my files that I just came across a couple weeks ago. I pulled out, it's an old file from the mid-1970s, making an incredible, almost hysterical point of the fact that there were 15 million people in this country with no health care and how unjust that was. Well, the number is 48 million now. And in another 10 years at this rate, it'll be 75 million. So, that's a downer. What are we going to do about this? I'm going to spend the rest of the time trying to answer that question. And one of the things I'm going to say is going to sound a little strange. In fact, when we move on to the next section of this talk, I'm going to talk about how we can use electronic medical records to do things we've never been able to do before. And that might sound like a little sort of small thing on this global canvas that looks so depressing, but I really don't think it is. We have unprecedented new opportunities to do things better and cheaper because we have unprecedented access to information. But we've got to collect it. We've got to pay attention to it. We have to have the resolve to do what's proven instead of what's fashionable. And we need to change institutional and system behaviors. And that is the last part of the talk, is going to be changing institutional and system behaviors. That's what I just said, so I don't have to keep harping on it. Okay, but first we're going to talk about better information through medical records, through electronic medical records. This quote from Lynn Etheridge: in health affairs, electronic health records databases from millions of people could rapidly advance the U.S. evidence base for clinical care. I hope I can convince you that's true. There are some barriers to overcome. But the availability of comprehensive, population-based, long-term information on medical information that's comprehensive and population-based, I know I repeated that, but it's important, offers us a way to rethink how we evaluate what we do and how we assess quality and improve it. For example, electronic medical records now allow us to examine how we did care in the past and how that is related to the outcomes of that care. If you can define different patterns of care. Now, this group of doctors did that, this group of doctors did that, and how did the patients do? We've never been able to do that before. It certainly, with a paper record system, was simply not practical no matter how much money you spent. Electronic records can identify care variations across systems and across practitioners. Not because we want to find the bad practitioners and point fingers at them, but because we want to look at patterns of care and how those patterns of care are related to outcomes so we can learn from it. That's what that's about. And costs, too. That allows us to pinpoint and facilitate repair of failures and implementation of successes, and helps us to figure out how to stop doing what doesn't work, which is one of the problems. Now, healthcare records also have this problem. They give us an enormous amount of information. Those of you who write academic papers from analyzed data are probably aware that if you ask a programmer or an analyst to give you all the data from your last study, you'll get a mountain of paper that you can't make any sense of at all. But if you start out thinking about what you need and you give them a set of dummy tables to populate, you will get coherent information. And that's what we need to learn how to do, because, of course, if you've got comprehensive medical records on 300 million people over a 10-year period and you ask for all the data output, well, it will exacerbate global warming because we won't have any trees left. So this little cartoon actually isn't that far from the truth. In a lot of cases, there's so much information out there that people just throw up their hands and do what they've always done. Too much information. Information can be of poor quality. It can be of good quality. In my own healthcare system, I've always been chagrined that they spend an enormous amount of money on surveys that ask people how their care experience was. And they send these out in the mail, and they get a 20% response rate. And they do this every 6 months or so, and they issue these lovely reports, beautiful graphs, beautiful figures. And by each question, if it went from 58% to 58.2%, there's a little green smiley face. And if it went from 58% to 57.8%, it's a little red frowning face. No statistical analysis. No worry about sampling. No worry about biased response or anything like that. If we put garbage in, we get garbage out. So the promise of electronic medical records always presumes you thinking through what you're looking at and what it means. Now, I'm going to talk to you about an approach that our group has developed, and we've been doing work on this for 9 years, in which we apply person-time methodology to electronic medical records. I'm going to tell you this only because it leads me to show you some graphs that illustrate what I'm talking about. There are other ways to get at this kind of information from electronic records. Person time is one way. Person time coverage means, very simply, how much time is covered that should be covered by some service. And I'll explain what that means in a minute. It helps us to set priorities, to identify and repair dysfunctional processes, and to transfer resources from areas of low benefit to high benefit. I'm going to talk about our prevention index measure because it's the simplest approach to this. The prevention index refers to any preventive service that has a recommended interval between deliveries, like a mammogram every 2 years, a pap smear every 3 years, lipids every 5 years, that sort of thing. If you take a given individual who's eligible, let's say, for a mammogram, and they have a mammogram on January 1st of 2004, they are now covered until December 31st of 2006. So all of that person time, those 2 years for that one individual, is now covered when they have that. And if they have it, if they don't have another mammogram until, let's say, June 30th of 2007, they have 6 months of uncovered time. So over that 2.5 years I mentioned, you'd have 2 years of covered time and 6 months of uncovered time. This is really how it works, and it isn't quite as simple as I just made it out to be. This will help me know where to go. How many of you don't know what HEDIS is? Anybody know what HEDIS is? Nobody knows? Nobody knows. Few people know. HEDIS is a system of outpatient quality assessment that is very much like the JCO, the hospital certifications for inpatient care. Many large healthcare systems subscribe to HEDIS, which means that every year they have to provide data on their populations. And HEDIS, of course, doesn't require electronic medical records because there's still a lot of healthcare systems that don't. One of the first points that I want to make is that the way we're doing it now is faulty. And using this example that's up there is one of the easiest ways to explain that. Sorry, I don't have a pointer. There must be somewhere here. Oh, here we are. In that example I talked about a minute ago, let's assume, let me get over here, I think it'll be easier, that a woman had a mammogram here, and that this is 2006, and she had a mammogram in January, or let's say March, at the end of March in 2004. So she's covered up through March of 2006, and then she's uncovered. And then let's assume that in September of 2006, she comes in and she has a lump on her breast, and she says, "Doctor, I got this big lump on my breast." And the doctor does a mammogram to diagnose it and finds a big breast cancer there. Now, if you were doing a HEDIS measure, you would say she was screened in September of 2006. Folks, screening is to find pre-symptomatic disease. She was not screened in September of 2006. She was diagnosed. It's a screening failure. If she had been screened earlier, they might have found it in time to have better outcomes. So all of these current measures, and HEDIS is the leading one, but it's not the only one, are unable to separate screening from non-screening services. The service is the same. It's a mammography. But you sure can't count your failures as successes and be accurate. So one of the things this person-time approach allows you to do, using an algorithm in a comprehensive medical record system, it allows you to select information that can distinguish between screening and non-screening services. So in our case, we now know, because of the ICD code, that this woman had a breast lump, and later on that it was diagnosed as a cancer, that this was not, and a symptom code for breast lump too, that we know that this was not a screening service. So we say when you have a non-screening service, you are not eligible for screening for one full service interval, which is 2 years. So we don't count you. We don't count you as a failure. We don't count you as success. You're removed from numerator and denominator. So the way this methodology works is she was covered for the first 3 months of the year, or 4 months of the year, through April, let's say. And then the next 4 months she was uncovered, and the last 4 months she wasn't eligible. So we would say that her PI, her prevention index for the year, was 50%, or 50, which is half the time she was eligible, she was covered, half the time she wasn't. Now that you apply that to every screening service, and you get a score that can be added up across individuals, across practitioners, across years, and even across services, to look at what is the relationship between how close you meet evidence-based guidelines, you need an evidence-based guideline, and what your outcomes are. If evidence-based guidelines are accurate, how closely you meet them should be related to outcomes. And we can actually find that out now. And if it turns out it's not related to outcomes, I'd suspect the guidelines are in error. At least if you can repeat that in several populations, that's probably true. Now you can also apply the same approach to managing diseases. Diseases that have set target goals. For example, treating hypertension. Your blood pressure should be below 140 over 90. How much of your person time is it above that level? That's a quality measure. And also, how far above that level is it? And that's what this level does. In this particular graph, this is the goal blood pressure. Let's say we're talking about diastolic blood pressure and the goal is 90 or below 90. And the person came in at time 1 and they were below 90, so there's 0 there. And they came in at time 2 and they're at 98, so they're 8 millimeters above goal. And they came in at time 3 and they're at 100, so they're 10 millimeters above goal. The area under this curve represents a period of time above goal that is adjusted for the amount of time you're above goal. You can now look at what's the relationship of that to outcomes of disease that treating hypertension is designed to prevent, primarily congestive heart failure, stroke, and also myocardial infarction. So you can actually say, what is the relationship between how well you're being treated and your outcomes? Okay, let's give you some quick, simple examples of how this works. You can have lots of data, but if you organize it right, you can learn things. Now, each of these is going to be a real simple graph based on these person time measures, and it's going to have a lesson in it. This one reflects screening in a large HMO, not mine, another one that we worked in. In 2002, and we were looking at the percentage of person time that they were adequately screened for lipids. You're supposed to be screened according to the U.S. Preventive Services Task Force every 5 years, and that's not very often. You don't have to get screened very often. And what did we find out? We found out that half the people, just about half, this half over here, were screened 100% of that 5 years. And in fact, a lot of them were screened 5, 6, 7 times during that 5 years. And remember, like the mammogram example I gave before, we were not counting time that people have been tested for lipids if they are hyperlipidemic, they're on statins, they have cardiovascular disease. Those are treated separately. This is just true screening. And half the people were never screened. This is the proportion who had 0% time. So 42% of the population had no time covered by lipid screening over a 5-year period, and 46% had 100% of time covered. And the lesson from this is, listen, don't worry about all the people in between. There's hardly any of them there. If you want to improve screening, you find out who's not getting screened at all and go after them. That's where the unscreened screened person time is. And so that helps you plan strategies to improve screening. I actually participated in a campaign years ago to improve cervical cancer screening, and we didn't realize this kind of thing. And we put up posters to try and encourage women to get screened more frequently. And the average interval between women who used to be screened every 2 years, every 1 year, which was too often. But the average interval among that group went to 9 months as a result of these posters. But before we started that campaign, 8% of the population hadn't been screened in 5 years or longer. And when we finished the campaign, 8% of the people hadn't been screened in 5 years or longer. The people who were most at risk were not affected by that at all. This kind of data tells you, don't just stick up posters saying get screened more often, because they won't appeal to the people you're after. You have to do something different for them. This is the percent of person times in that same HMO that people with high blood pressure were below goal in a large HMO, the same one, over a 4-year period, 1999 through 2002. And I know there's a lot of bars there. So just look at the blues. This says these people in dark blue were never, in that year, never once had a blood pressure below 90, if we're talking about diastolic blood pressure. Actually, this is for both systolic and diastolic. So they were never, in the whole year, a quarter of the population below goal. And these people, only a quarter of the people, the white bars, were below goal the entire year. Everybody else had some time above goal. And overall, 45% of all of the person time of people with diagnosed hypertension on therapy, for nearly half of their person time, they were above goal. That's pretty poor management. And it's not, this is a pretty good healthcare system. In fact, it's been written up in Newsweek for how the quality of their care. Here's another example of looking at coverage for for influenza vaccination. Now, we immunize for flu during the flu season. So here the operative period isn't a calendar year. It's from September of one year to February of the next year. That's the period that you're interested in. And you had this huge drop-off in 2001 and 2002. And that happened because CDC was late delivering the vaccine. Now, normally speaking, we see that. We'd say, oh, well, CDC was late. The fact is you lost a substantial portion of your opportunity to prevent influenza and deaths and disabilities associated with influenza by delivering the vaccine late, because now a substantial portion of the flu season was uncovered for anybody. This is a very important public health problem that isn't addressed, even to my knowledge, by CDC. They just say it's going to be late. Now, a while back we talked about colorectal cancer screening as the most effective screen in preventing death. And it is. This represents, in that same nameless healthcare system, which was written up in Newsweek and in Time, they have 336 primary care practices in that system. And this is the number of practices, here, the number, that had colorectal cancer screening prevention index scores. Remember, the prevention index score means percentage of person time covered by the service as recommended. Now, these scores are for all of the people in each clinical practice who were eligible. So if you had a physician with 1,000 people in his or her practice that were eligible for colorectal cancer screening, this would be the average of all 1,000 of their scores, of their PI scores. And what we found was that there is the average practice period of time covered by colorectal cancer screening was about 30%, not very good. And the range was, a little bit of a tail there, but not a lot. To me, this suggests that there's a system problem because everybody's low. It suggests there's some barrier to getting colorectal cancer screening. Maybe it's patient reluctance. Maybe it's that the system, and this was true, the system didn't have enough sigmoidoscopy and colonoscopy screening slots to accommodate the need. And that was why these were so low. In contrast, this is the same data for their mammography scores in the same year. And you can see that the average score was around 70, and that's pretty good. I think you're not going to do a lot better than that. You're certainly never going to get 100%. You're not going to get a whole population of anybody to do anything. So, but look at this. This is a long tail of around 20 practices that were doing very poorly. Now that suggests one of two things. Either these are physicians who are just not paying attention to mammography, or you've got maybe a clinic somewhere that's not functioning well because something's different about it. And it turned out that's what we found. There was one clinic that had a totally different way of making mammography referrals, and people were rolling off the table like mad. They just weren't picking them up. They didn't even know about it until we showed them this. And that clinic changed their processes immediately, and it doesn't look like this anymore. That's another thing you can do with these kinds of data. Now, everybody knows the healthcare system and physicians don't know how to deal with obesity, right? As people throw up their hands and say, nobody knows how to deal with obesity. Well, we wanted to test that really quick. We did this analysis, and I confess it is unadjusted. We should go adjust for demographics, but this was to show what we could do fast and dirty. We did this in about half an hour, pulling stuff out of the databases. What is this? This is, again, the number of practices. And we asked the question, if we take all the patients in each practice who have a body mass index over 30, that's obese by definition, in 2002, and we asked how many of those people had lost weight by 2005. We found two practices over here that more than 70% of their obese patients lost weight over a 3-year period. Can you believe that? That was stunning. Actually, we were surprised that the average was about 50%. But, this tells you, go look at those two. Go find out what they're doing. They're doing something meaningful. Now, the next two slides are just summaries to show you how these things look for different services. Again, these bars, this represents a little different than the previous one. This is the lowest scoring practice. This is the highest scoring practice. This is the median and the 25th and 75th percentile. And these are all compared to U.S. Preventive Services Task Force standards. So what I want to draw your attention to isn't the exact scores. It's the practice variation. It's the difference between this and this, or even between the mean and the high score. Because the high scores represent... Oh, thank you. Thank you. The high scores represent what you can accomplish in this environment. It's doable. The low scores represent what the people who aren't paying any attention are accomplishing. And the rest is in between. Oops, wait a minute. This is same scores for flu vaccination, pneumococcal vaccination, colorectal screening, chlamydia screening, and screening for osteoporosis. Again, the lesson, what I'm after, is variation. And I'm going to go through the next few. I think I've made enough points. This shows that although young males are at much higher risk of cardiovascular complications of high blood pressure than young females, and they also have higher blood pressures, we are screening young males far less than we're screening young females. And in fact, they don't intersect until age 80. So our screening patterns are not related to risk patterns at all. This one is the only slide that's hypothetical. And what I'm doing now is a study that is going to fill this in with real data. But these are made-up data. These are my hypotheses. This is interactive PI is a summary score that's made of the individual prevention index measures for tobacco counseling, nutrition counseling, physical activity counseling. It's the attention that physicians are paying to lifestyle variables. And so the hypothesis is that those physicians who score higher will have fewer days in the hospital, fewer cardiovascular disease events, and fewer office visits per year. Now, I don't know that that's true. These data are made up. But the fact is, this approach allows you to answer that question. So when this doctor says, hey, I'd like to do more prevention, but there's just not time, you can say, wait a minute. This guy says he has plenty of time because he doesn't have so many patients in the hospital. Is that really going to happen? Sure it is. You know that, right? It's going to happen that way. I mentioned HEDIS scores. I'm not going to even pay attention to this. If any of you are interested, we can look at it. But this is a comparison. But if you're not familiar with HEDIS, it won't mean anything. But this is useful. This is the percentage of all of these screening tests that were diagnostic and monitoring rather than preventive. So when you do a quality measure that includes diagnostic services, you're diluting prevention by more than a third for mammography, for about a fourth to a fifth for PAP. Half of your lipid tests are non-screening, and so on. You can see that lumping these together gives you information that doesn't have a lot of meaning. And I'm going to skip this. This just shows the difference in scores at the clinic level, and it shows that there are variations. And so I'm going to skip over it and move on. Once you've found this stuff out, you need to make responses at the system level. Here's what we found out by looking at those data. We were screening low-risk people more effectively than we were screening high-risk people. And I showed you one slide on that, but there are really lots of them. the people who get screened the most aren't the people who need it. We had a declining mammography screening rate over time. I didn't show that one. We had half of the hypertensive person time above goal. We had half of recommended person time for preventive care was not covered. We had a wide range of performance. We interpreted diagnostic testing as screening success. Half of our preventive care was an excessive recommendation. I didn't show you that. And we now found some high performers, and we didn't know how they did it. It gave us a place to look. This approach can also allow you to measure the costs of unnecessary care. If you take U.S. Preventive Services Task Force guidelines and you say that's how we ought to do it, you can go in, remove the diagnostic test, and ask, are we screening in excess? Are we delivering too much of anything? And the answer was, yeah, we were delivering a lot of excess care. But I'm not showing those data here. And we can determine whether the adherence to the guidelines improves health or affects cost. And that's another on excess deficits, and I'm not going to get into that. I'm going to close out this section and get into the last part about what we have to do by showing you that when we go to EMRs, we do lose something important. In automated medical records, there are a lot of macros. So a physician can simply click on a button that says something like, patient is a smoker, set a quit date of, fill in the date, call back on such a date to check with it. So he doesn't have to write that out. It's very clear. But we lose things like this. These are real excerpts from medical records. Patient gets chest pain if she lies on her left side for over a year. She has no rigors or shaking chills, but her husband states she was very hot in bed last night. Discharge status alive, but without permission. The patient will need disposition, and we will therefore get Dr. X to dispose of him. Healthy appearing, decrepit, 69-year-old male, mentally alert but forgetful. That's my favorite. And the patient left the hospital feeling much better except for her original complaints. I don't know how you code those, but they're fun. I'll miss them. Okay. I've gone over that enough. We're going to skip over the summary and get to changing personal behaviors. We have to change personal behaviors, and we have to change system behaviors. Lifestyle interventions are, frankly, largely outside the paradigm of what the healthcare industry perceives as its proper business. And the way you know that is you can't sue them if they don't do it. They're not accountable for it. There are no standards. Nobody says, here's the national standard for doing tobacco interventions in healthcare. That's what you have to adhere to. There's no such thing. There's a huge literature on it. Same is true for nutrition and weight and so on. Huge literatures, no standards, no accountability. Hey, it's not in the paradigm. So, but personal beliefs, yours and mine and patients in every healthcare system, have a lot to do with the problem. Some patients say, hey, I should get anything I want. I'm insured. Doesn't matter. If I want it, I'm entitled to it. And believe me, if you've ever worked in a healthcare system, you know that there are patients like that. The other problem patient is the patient who says, what do you think I'm paying insurance for? If I'm unhealthy, it's the doctor's fault. Once I have made a change, once I lost that weight, I can go back to the way I was before. Of course, that's exactly what happens. They go back to the way they were before. So how can you change personal lifestyle behaviors? Well, I'm sure a lot of people in this room are very up on this, and deliberately I'm not going to spend a lot of time on it. I don't have magic answers. But we do have to have programs that take into account what the current knowledge base is. And the current knowledge base says, hey, credible, consistent sources of advice lead to sustained behavior. Is our healthcare system credible and consistent on lifestyle? Personal commitment, that's the individual's choice. If the individual wants somebody to do it to them, it fails. Knowledge of healthy behaviors, of course, knowledge isn't enough, but you can't eat right if you don't know how. It's important. Support, social support, is a critical element to succeeding in lifestyle change instead of social sabotage, which is often the alternative. Long-term maintenance is crucial. Long-term maintenance. I did a survey a couple of years ago of obesity programs in 16 large healthcare systems. I found probably 50 different programs. One of them had unlimited opportunity to come back. Like, Weight Watchers allows you to keep coming back to groups as long as you want and as often as you want. Only one of these healthcare systems had a program that allowed you to do that. The other 49 programs, it was like 6 weeks, 8 weeks, 5 weeks, 10 weeks, and then you were done forever and ever and ever. So that's not knowledgeable behavior change. People need to have realistic expectations, and I think it's the healthcare system's responsibility to teach them those realistic expectations. We need to be saying to people when they join health plans, we're going to give you evidence-based care, and we're not going to waste your money giving you care that we have evidence doesn't work. Health systems have to support healthy lifestyle behaviors in the same way they support treatment. Now, you walk into the doctor's office with a BMI of 32, there's a very good chance the doctor will never mention your weight to you. You walk into your doctor's office with a systolic blood pressure of 145, and he's going to be climbing all over you to take this pill. That's not very rational. Well, the latter one is okay, but ignoring the former one isn't. We have to have standards of care that apply to lifestyle behavior change in healthcare systems, and accountability for applying them, and even liability for not applying them. Changes in lifestyle are hard to sustain. Individual choices are the most important determinants of a person's health. Somehow we have to get that message across to consumers. And I've been trying for 30 years to get Kaiser Permanente to try to do that. And they're too afraid that if they try to do that, people will leave town. They'll go to the next health insurer over down the street. So they won't take it on. We need consistent messages and support for lifestyle change and realistic expectations. Good information, and where do they get good information? Right now they're not getting it either from their schools, and they're not getting it from the healthcare system. So do we need a whole new system to do this, or do we need to change curricula and the messages that they're getting in our healthcare system? Now, for the last few minutes, I'd like to talk about system behaviors, because the truth is we can't get out of this dilemma of our healthcare system if we don't change what we're doing. I don't have to tell you about the gap between research and clinical practice, but that's underlying a lot of this. Data are very clear. Physician advice changes behavior. Treating disease is more important than preventing it. We say patients are naive about that, but healthcare systems certainly act like that's what they believe as well. If someone is insured, they're entitled to any care they want. That was also a personal behavior that was a problem. It's a problem in our system because our system exceeds to that. Not 100%, but largely. If you want it, particularly if we used to deliver it, we got to deliver it now. To compete, we got to have all the latest technology. How do we get out from under that? I don't have a magic answer. We've got a system that says if you're that hospital administrator, you've got to buy that MRI machine or you're going to go out of business. How do we break that? How do we break the fact that every hospital is cluttered to the gills with technology it doesn't need? I don't have a magic answer, but we got to do it. We need to prioritize facilities and services. We need to reduce unnecessary care, which is the most care, frankly. We need to reduce the bureaucracy to practice evidence-based medicine, and automated medical records allow us much more than we could in the past to get evidence on practices we could never afford to do clinical trials on. We need to share risk. And here's another one. In the late 1980s, Congress changed the law and said, for-profit health plans, you guys can go out and insure whoever you want. But you nonprofits, you have to take everybody. And the result of that was that over the next 5 to 6 years, about 80% of the nonprofit health plans went out of business. And a few years later, in the first term of the current Bush administration, the nonprofits were screaming at the government, look, we can't compete. It's not an equal playing field. You have to give us the same break. And so they did. So now the nonprofits can also enroll anybody they want in cheap health plans that don't share the risk. We've developed a system whereby if you're sick and you need health care, you can't get it. And if you're well and don't need health care, you can get it. It's a very irrational system. The whole notion of insurance is shared risk. We've eliminated shared risk, and the consequence is 48 million uninsured people. We have to be accountable for evidence-based effective care. Health behaviors are a trivial, boring part of curriculum that deserves little serious attention. This is an educational belief at every level from grammar school to medical school. Physical activity. Now, I don't know how old you are, but when I was in school, in high school, it was a law that I had to exercise at least an hour a day. Now, how many have laws? Is there any law like that in New York? You have to exercise? There is? Don't? I'm talking about the schools, yeah. There is. Well, more power to you, because in every state I have lived in for the last 30 years, those laws have gone away. They used to exist, and they've been revoked. Gym has been a casualty of the downturn in educational funding. People learn this stuff on their own or from doctors. It's not our responsibility. We're talking about the education system again. We need to teach sound nutritional and physical activity practices, model sound nutrition and physical activity practices in our cafeterias, in our gyms, in our institutions. We have to have healthy, good-tasting foods in our vending machines. I'm currently doing a research study where we're looking exactly at how to do that. We've had amazing luck with employers in changing the foods offered, but they had never thought about it before. And, of course, we need to require physical activity. It keeps us wealthy. Now, political belief. We think that corporations are entitled to buy congressional support through campaign contributions. We think that the U.S. leads the world in health care, that health care reform is death to politicians and they better avoid it, and single-payer systems are socialized medicine and therefore are evil. Now, I'm not necessarily an advocate of single-payer systems. I'm just a non-advocate of vastly complex, idiotic, ununderstandable payer systems like the one we have. Single-payer systems work pretty well in the countries that have them. If you look at the countries that have the top 20 life expectancies in the world, none of them have more than 2 or 3 payers. It makes a difference. We need to use scientific expertise to make policies, eliminate special interest funding. I mean, if we had to do one thing, I would say that's the one. Because right now, we can't change the rules because the people who can do that owe their jobs to those special interests. We need to look at the data and learn from other nations. I mean, my gosh, you could take the 21 developed nations in those slides that I had and put their names on the wall and throw a dart at them and adopt their system, and we'd have better outcomes and lower costs. It's not like this is highly complex. I mean, it's highly complex in the sense that we have to dismantle a very large, complex system that exists now. That's hard. But picking what to do isn't hard at all. There are models all over the world. We need to demand health care reform. And if there's a politician running for office next year who won't talk to you about it, vote for someone else. Here's how much industry lobbying gave to Congress in the 2006 off-year elections. $161,000 per candidate. It's hard to run for Congress if you give up that amount of money, and instead it goes to your opponent. The increase in lobbying from the healthcare industry since 1990 through 2006 is 456%. $161,000 per candidate, 83% of it to incumbents. A sound healthcare system requires legislative change. We will not succeed in saving our healthcare system if we don't get healthcare reform of some kind, some meaningful kind. Special interest money distorts the legislative process to the point that we cannot address these problems. So, in closing, here are the things we have to do, and they're at the personal level, the health system, and the legislative level. We need to prioritize care, reduce unnecessary care, reduce bureaucracy, follow evidence-based medicine, share risk in insurance. We need to remove the special interests from making the decisions for us, and that's a personal decision because we elect those people as well. There is a large literature on changing personal behaviors. But there isn't a big literature on changing system behaviors. And for those of you who do research, particularly sociological research, I would challenge you to think of this seriously. How do we get systems to change? Because our problem here is, a big part of it is system behaviors. Systems are independent of the people who are in those systems. They have their own life. And we've spent a lot of time and money figuring out how to help people change their behaviors. We need to spend some of that time and money in figuring out how to change the systems that are having an adverse effect on our life. So, individuals, health systems, and legislators must act if we are going to have a healthcare system that remains intact. Now, the alternative is the system will collapse and we'll put it back together somehow. But there'll be a lot of chaos and a lot of wasted money and a lot of people who will suffer in the interim if we don't do that. A lot of oxen will be gored, and a lot of folks will resist change if we're to do this. But let's face it, the status quo is no longer